These tapes demonstrate a standard for the neurological exam on spinal cord injured persons. Because the method is designed for use in the supine position, it can be used consistently for all testing from acute through rehabilitation and during lifetime follow-up. It allows clinicians and researchers around the world to share data and compare results. This tape is the first of a three-part series. It demonstrates the actual technique. The second tape is a tutorial and shows the use of the technique on spinal cord injured patients. The third video shows the functional independence measure for persons with spinal cord injury. The standards shown in this video have been developed by the American Spinal Injury Association and endorsed by the International Medical Society of Paraplegia. These international standards were published first in 1982. Each booklet contains a chart which may be copied and used for entering the scores collected by the examiner. This video demonstrates two aspects of the neurological exam. First, the sensory, and second, the motor. You may wish to refer to the manual for elaboration on certain sections of the exam. The first part of the neurological exam we will show is the sensory. We'll start by discussing dermatomes and locations of the key sensory points. Next, we'll show how the key sensory points are tested, first for sharp-dull discrimination, and then for light-touch discrimination. The sensory exam will conclude with a demonstration of deep pressure sensation and joint movement discrimination. In performing the sensory exam, you will test the 28 dermatomes as shown in the chart in the standards booklet. Each of the 28 dermatomes has two key sensory points, one each side. Using the key sensory points for each dermatome makes the measurement more reliable. When the key point is covered by a dressing or is otherwise inaccessible, the examiner may test an alternate site within the dermatome. If there is no alternate site available, the patient is not able to be tested for that dermatome. You may refer to the manual for the exact location of each key point. In order for you to complete the chart, you will have to test all dermatomes for both pin and light touch. Each dermatome must also be tested on both the right and left sides. For testing light touch, a cotton applicator is recommended. The applicator is used with a wisp pulled out from the tip. When you test the dermatomes for sharp, dull discrimination, a straightened safety pin is recommended. First, we'll demonstrate the test for sharp, dull pin sensation. This test determines whether or not the patient can differentiate between sharp and dull ends of the safety pin. First, touch the patient's face with both the sharp and dull sides of the pin. If the patient can distinguish between the sharp and dull sides without looking at the pin, ask the patient to remember the feeling for the rest of the examination. When testing each key sensory point, press the blunt and sharp ends in a random order on the key point. This is a downward movement with sufficient pressure to elicit a normal response. Ask the patient if he feels the touch and whether the sensation is sharp or dull. Test each key point several times with the two ends of the pin. If the patient is unsure about the comparison, re-establish the baseline reference. The method for scoring each dermatome on the chart is to enter one of 4 possible scores. If there is no perception of being touched or no consistent ability to distinguish between sharp and dull, the score is 0. If the patient does differentiate between sharp and dull, but the intensity of the sharpness is greater or less than the baseline, the score is 1. If the patient reliably and consistently distinguishes between sharp and dull and states the intensity of the sharpness is the same as the baseline, the score is 2. Finally, if there is no accessible point on the dermatome due to coverings, tissue damage, amputations, or patient unreliability, enter not testable with the letters NT in the appropriate block. You may wish to note the reason next to the score. At the end of the test, be sure you discard the safety pin in a medical waste receptacle. We will now demonstrate the test for light touch discrimination. This test uses the same key sensory points that were used for pin discrimination. Pull a wisp from the end of a cotton applicator. Touch the patient's cheek using a light stroking motion. The stroke does not exceed 1 centimeter. During this time, the patient's eyes are closed or blocked. If the patient can feel the touch and identify where it is, ask him to use the feeling as a point of comparison. After you have established this baseline, test the sensory points on both sides for each dermatome. There are 4 possible scores. 0, the patient has no sensation of being touched. 1, the patient correctly identifies the touch, but feels it as greater or less than the baseline. 2, the patient correctly reports when he feels the touch and states the sensation is the same as on the face. Not testable when there is no accessible point on the dermatome due to coverings, tissue damage, amputations, or patient unreliability. Enter NT in the appropriate block. At this point, we have learned about dermatomes, key sensory points, and testing for pin and light touch. Next, we will look at techniques for examining dermatomes that are hard to get at when the patient is supine and in traction. We will look at C2, S2, S3, and S4-5. The key point for the C2 dermatome is at the occipital protuberance. Since this is often inaccessible, you may also test the dermatome in the area just behind the patient's ear. When you test the key point for the S2 dermatome, which is behind the knee, you will have to raise the patient's knee as demonstrated here. You may need assistance to do this. When you examine S3, you will need to further raise the knee to reach this point. The key point for the S4-5 dermatome is within 1 centimeter of the anal cutaneous junction. In addition to the pin and light touch parts, there are 2 more tests. These are for joint movement discrimination and for deep pressure. Except for anal sensation, neither of these scores are recorded on the chart. When you test for joint movement discrimination, hold the part of the limb being tested on both the lateral and medial sides and move the joint in alternate directions from a mid-position of its range of motion. The patient's eyes should be closed or blocked during the procedure. Ask the patient to state when he feels movement and what direction the movement is in. Move the limb in each direction more than once and in various degrees of movement. Even small movements of the joint are accurately perceived by people with normal sensation. There are 4 possible scores for this test. The score is 0 if the patient is unable to identify joint position at least half the time. If the patient accurately perceives the joint's position more than half the time, but not 100% of the time, the score is 1. If the patient consistently and accurately perceives even the smallest joint positions every time, the score is 2. If the patient cannot follow directions, or the joint cannot be moved because of fracture, immobilization, or amputation, then mark NT in the appropriate block. The joints to be tested are shown in the manual. The last part of the sensory exam is the examination for deep pressure. For this test, you will use your index finger and apply firm pressure to the pressure point for 3 to 5 seconds. Establish a baseline or point of reference by pressing on the patient's chin. This also establishes the patient's reliability for participation in the exam. Also ask the patient to describe his sensations when pressure is not applied in order to be certain that the perception of deep pressure is reliable. With the patient's eyes closed, ask him to indicate when he feels pressure in the tested location. If the patient has no feeling when you apply pressure, the score is 0. If the patient reliably reports feeling some pressure, the score is 1. As before, if the area is not testable, mark NT. For the location of the 6 key pressure points, please see the manual. The final part of the deep pressure exam is the test for deep anal sensation. This test is sometimes the only initial evidence that a lesion is incomplete. The test is performed by doing a digital rectal exam. Ask the patient if he feels anything. Deep anal sensation is recorded as absent or present without reference to a normal feeling. Also, ask the patient to contract his anus and mark the result in the motor exam. This concludes the section on sensory testing. The next part of the neurological exam is the motor exam. Before starting to view that part of the tape, you may wish to review the materials in the manual. Like the sensory exam, the motor exam refers to the chart in the International Standards booklet. This test is conducted on 5 upper and 5 lower extremity muscles. All 10 muscles are graded on both the left and the right sides. The grading scale for each muscle goes from 0 to 5. The score is 0 for a muscle if there is no palpable or visible contraction. The score is 1 when there is only slight palpable or visible tensing, or when movement is not through a full range of available motion. The score is 2 if there is only a full range of motion with gravity eliminated. If there is only a full range of motion against gravity, the score is 3. The score is 4 if the patient can move the limb through a full range of motion against some resistance, but not against normal full resistance. If the patient moves the limb through the available full range of motion against full resistance, the score is 5. If the limb cannot be tested because of pain, casts, poor positioning, or amputation, put NT for not testable in the appropriate box. Our demonstration starts with the 5 upper extremity muscles, the elbow flexors, the wrist extensors, the elbow extensors, the finger flexors, and the finger abductors. Testing for the C5 motor level is done with the elbow flexors. During the test for grades 0 through 2, the patient's elbow is 30 degrees from full extension with the hand just below the navel. This is the gravity-eliminated position for this muscle. Ask the patient to bring the hand to his nose. If there is no visible or palpable movement, the score is 0. If you see or feel any muscle contraction or slight movement of the forearm, the score is 1. If the patient moves his forearm through a full range of motion with gravity eliminated, the score is 2. For grades 3, the arm is extended and parallel to the chest. If the patient can move through a full range of motion against gravity, the score is 3. For testing grades 4 and 5, you should brace the patient's shoulder with one hand and pull on the volar aspect of the wrist with the other. Note that the hand is supinated during this operation. You will then ask the patient to not let you pull his arm down. If the patient is able to offer some resistance, the score is 4. If the patient offers normal resistance, considering age, weight, and gender, the score is 5. The next test is for the C6 motor level. This is done on the wrist extensors. While you are testing grades 0 through 2, the wrist is in a neutral, gravity-eliminated position with the wrist in full flexion. Ask the patient to dorsiflex his wrist. If there is no visible or palpable movement, the score is 0. If there is a slight movement or muscle contraction, the score is 1. A score of 2 is given if the patient moves the wrist through a full range of motion with gravity eliminated. The tests for grades 3 through 5 are done with the forearm completely pronated and your hand placed on the patient's wrist, which is in full flexion. If the patient moves through a full range of motion against gravity, the score is 3. In testing grades 4 and 5, press against the dorsiflexed wrist in the direction of palmar flexion and ulnar deviation. If there is some resistance, the score is 4. If there is full resistance, the score is 5. The test for the C7 motor level is done with the elbow extensors. While you are testing for grades 0 and 1, the elbow is 30 degrees from full extension with the hand just below the navel. Support the patient's forearm to keep it parallel to the examination table. Ask the patient to straighten his arm. If there is no visible or palpable movement, the score is 0. If there is slight movement or muscle contraction, the score is 1. For grade 2, the elbow is fully flexed. If the patient can extend his arm from a fully flexed to a fully extended position, the score is 2. For grade 3, the upper arm is 90 degrees to the table and the hand is by the ear. If the patient can bring his arm to complete extension, the score is 3. Grades 4 and 5 are tested with the elbow 45 degrees from full extension and the shoulder is at 90 degrees. Grasp the wrist and try to flex the elbow against the patient's resistance. If there is some resistance, the score is 4. If the resistance is maximal or normal, the score is 5. The test for the C8 motor level is done with the finger flexors of the distal phalanx of the middle finger. With the patient's hand in a neutral position and the proximal interphalangeal or PIP joint of the middle finger stabilized, ask the patient to flex the distal phalanx. If there is no palpable or visible movement, the score is 0. If there is any movement that is not a full range of motion, the score is 1. If there is a full range of motion, the score is 2. For grade 3, the hand is supinated and the PIP joint is stabilized. If there is a full range of available motion, the score is 3. Grades 4 and 5 are given by continuing to stabilize the PIP joint and attempting to extend the distal phalanx. If there is some resistance, the score is 4. If there is normal resistance, the score is 5. The test for the T1 motor level is done with the abductors of the little finger. The patient's hand is placed palm down on the table, fingers together. Gently press down on the back of the hand and ask the patient to spread his fingers. If there is no visible or palpable movement, the score is 0. If there is a slight movement only, the score is 1. If there is a full range of motion, the score is 2. Grade 3 is tested with the patient's upper arm perpendicular to the table and his hand over his chest. If the patient moves the little finger through a full range of available motion, the score is 3. Grades 4 and 5 are given with the hand pronated and the fingers spread. If there is some resistance when you try to force the little finger, the score is 4. If there is maximal resistance, it is 5. After you have obtained scores for the 5 upper extremity muscles, you will examine and score the 5 lower extremity muscles. They are the hip flexors, the knee extensors, the ankle dorsiflexors, the great toe extensors, and the ankle plantar flexors. The test for the L2 motor level is done with the hip flexors. The tests for grades 0 and 1 are done with the hip in the neutral position and slightly flexed. Palpate the hip flexor. If there is no contraction or movement, the score is 0. If there is slight movement, the score is 1. For grade 2, the patient's hip is in external rotation and the leg is supported to reduce friction. For grade 3, the patient must move the hip to a 90-degree flexion against gravity. The heel should be off the bed. Please note the precaution in the manual for thoracolumbar instability. For grades 4 and 5, you should brace the opposite pelvis and push down on the thigh just proximal to the knee. If there is some resistance, the score is 4. If there is maximal resistance, the score is 5. The test for L3 is done with the knee extensors. While you are testing grades 0 and 1, the patient's hip is in neutral rotation. You should slightly flex and support the knee. Ask the patient to straighten his knee. If he is unable, the grade is 0. With slight movement, the grade is 1. Grade 2 is done with the hip in external rotation. If the patient completely extends the knee in this gravity-eliminated position, the grade is 2. When you assess grades 3, 4, and 5, place your forearm under the knee of the leg you are testing and grasp the opposite knee. The patient's knee is at a 30-degree angle. If the patient can straighten his knee, the grade is 3. When testing grades 4 and 5, push down on the leg above the ankle. If there is some resistance, the score is 4. If there is maximal resistance, the score is 5. The next test is for the L4 motor level. This is done on the ankle dorsiflexors. When you are assessing grades 0 and 1, ask the patient to pull his foot towards his shin. If there is no movement, the score is 0. If there is slight movement, the score is 1. For grade 2, the hip is in external rotation. If there is complete dorsiflexion with gravity eliminated, the score is 2. When you assess grades 3, 4, and 5, the patient's ankle is in a neutral position with the toes pointed toward the ceiling. If the patient can move the foot through a complete range of motion, the score is 3. When you test for grades 4 and 5, place your hand on the patient's forefoot to provide resistance. If there is some resistance, the score is 4. If the resistance is maximal, the score is 5. Next, we will test the motor level for L5, the extensor of the great toe. With the foot in a neutral position, ask the patient to bring his toe toward his shin. If there is no movement, the score is a 0. If there is any movement short of a full range of motion, the score is 1. Grade 2 is tested with the hip in external rotation. A full range of motion is a score of 2. A full range of motion against gravity is scored as a 3. For grades 4 and 5, you should resist the extension by trying to flex the toe as shown here. The last motor level you will score is S1. To assess this level, we will use the ankle plantar flexors. For grades 0, 1, and 2, the leg is in external rotation. If there is no visible or palpable flexion, the score is 0. For a slight movement, the score is 1. And for a full range of motion, the score is 2. For grade 3, the hip will be in the neutral position and the knee fully flexed. Ask the patient to plantar flex his ankle, raising the heel off a firm surface. If the patient can lift the heel off the surface with his ankle plantar flexors, the grade is 3. To assess grades 4 and 5, Press against the plantar flexed foot. If there is moderate resistance, the grade is 4. If there is maximal resistance, the grade is 5. This completes the demonstration of the standard neurological exam of spinal cord injured patients. The information contained in this tape is fully detailed in the manual.
The neurological exam for spinal cord injury is a modification of the standard neurological exam. Since it's performed in the supine position, it's consistent and reliable at every stage from acute through long-term follow-up. During this video, you will get experience in recording the scores on the neurological form and reaching conclusions based on these scores. You will see an examination on a person with tetraplegia and a person with paraplegia. While you're watching, you will be asked to enter scores for each patient, then total their scores, determine the neurological levels, fill in the complete or incomplete box, note the zone of partial preservation, and assign an ASIA impairment grade. You should make copies of the score sheet located in the appendix of this manual before proceeding with the video. These are the copies you will use while you are watching. You will have 5 seconds to enter each score. There will also be sections where the video will ask you to pause the tape and check your scores against the answers, which you'll find in the appendix of this manual. The tutorial will begin with a patient with involvement in all 4 extremities. We will examine first for pinprick sensation. We will start testing with C2. The patient reports normal pinprick sensation on his right and left sides. Enter your score now for C2. Here the patient has normal sensation on both sides. Enter your score now for C3. For C4, the patient feels normal sensation on both sides. Enter your score now for C4. Here the patient feels the pin, but it is not like the sensation on his face. Enter your score now for C5. For the C6 dermatome, there is no sensation on either side. Enter your score now for C6. There is no sensation from C7 through S4-5, nor is there any anal sensation. Fill in the rest of the pinprick chart and the yes or no box for anal sensation. We will only test 3 segments for the light touch exam. First, we'll test C4. The patient says he feels normal light touch sensation on the right and left. Enter your scores now for C4. For the C5 dermatome, the light touch feeling is impaired on both sides. Enter your scores now for C5. Here the patient has no sensation on either side. Enter your scores now for C6. The rest of the light touch scores are the same as the pin scores. Please record the light touch sensation scores for C7 through S4-5 and add up all the scores for both the left and right sides to come up with a total score. Check your answers against those in the appendix. After you've checked the answers, return to the tape for the motor exam tutorial. Pause the tape now to check your scores against the answers in the appendix. We will now conduct a motor test on the upper extremity muscles of this patient. The patient has a complete cervical lesion. The scores in the lower extremities are all zeros. The exam starts with the elbow flexors. He has full normal resistance on both sides in the elbow flexors. Enter your scores now in the C5 box. The wrist extensors have normal resistance on the right side, and he is able to provide moderate resistance on the left. Enter your scores now in the C6 box. The right elbow extensor has a trace movement, and the left can only move through a full range with gravity eliminated. Enter your scores now in the C7 box. There is no movement in this muscle on either side. Enter your scores now in the C8 box. The finger abductors also show total paralysis on both sides. Enter your scores now in the T1 box. Since the injury is complete, the scores in the lower extremities are all 0. Now that you have completed the examination, complete the score sheet by totaling the scores. At this point, you can also fill in the neurological level, the section on complete or incomplete, and the zone of partial preservation, which is only for complete injuries. On the back is the Asia Impairment Scale, which you should also fill out. Check your answers in the appendix of this manual. The manual will also cover clinical syndromes. Pause the video until you are finished and have checked all your answers. When you're ready to continue, we will conduct an examination on a paraplegic patient. The second case has partial paralysis and sensory loss from the lower trunk down. We'll start with the exam for pinprick sensation. The score sheet is already filled out for dermatomes C2 through T4. The patient has normal pinprick sensation in those areas. We will start testing with T5. The patient states the sensations on both the right and left sides are normal. Enter your scores now for T5 on the right and left sides. Here the patient feels the difference between the sharp and dull ends, but says it's different from the feeling on the face. Enter your scores now for T6. The patient feels the difference between sharp and dull ends on the left and right sides, but states the feeling is more intense than normal. Enter your scores now for T7. The patient is unable to distinguish between sharp and dull ends of the pin from T8 down. Enter the scores now for T8 through S4-5. Note the method for moving the legs to test the dermatomes for S2 through S4-5. You should also note the precautions for pain or thoracolumbar instability mentioned in this manual. For the S4-5 dermatome, there is no normal sensation, but the patient does feel something. In addition, he does have anal sensation in response to a digital examination. Enter your scores now for S4-5 and check yes or no for any anal sensation. For the light touch exam, this patient reports normal sensation from C2 through T5. We'll show the tests for T6, T7, and T8. Here, the patient's response is normal for both sides. Enter your scores now for T6. For T7, he feels the touch, but it is impaired on both sides. Enter your scores now for T7. The patient's feeling is also impaired here and for all the rest of the dermatomes, both left and right, from T8 through S45. Enter your scores now for T8 through S45. Add up all the scores for both the left and right sides to come up with a total score. Check your answers against those in the appendix. Pause the tape until you are finished, and when you continue, we will do a motor exam and score it. The next part of the neurological exam is the motor exam, which is performed on 5 key upper and 5 lower extremity muscles. The patient has tested normal for all upper extremity muscles, so these scores are already filled in on the demonstration sheet. This part of the tutorial will show the lower extremities. The exam starts with the hip flexors. Note the restrictions for pain or thoracolumbar instability noted in the manual. Enter your scores for both sides. patient gives full resistance on the right side, but is only able to move through a full range with gravity eliminated on the left side. Enter your scores for both sides. Here, the patient offers moderate resistance on the right side and minimal resistance on the left. Enter your scores for both sides. For the long toe extensors, he has only a full range of motion against gravity on both sides. He cannot offer significant resistance. Enter scores for both sides now. The patient is unable to push his heel all the way off the surface, but he can move through a full range of motion with gravity eliminated. Enter your scores for both sides. Add up all the scores for both the left and right sides to come up with a total score. Also, fill in the neurological level and the section on complete or incomplete. The section on zone of partial preservation is filled in only if there is a complete injury. On the back is the ASIA impairment scale, which you should also fill in.